Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is coming to a state house near you. PYA is happy to present today's webinar on this important topic. And with that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Caitlin. Good morning, everyone. Thanks for joining us today on a different type of healthcare regulatory roundup. After 2+ years of talking almost exclusively about what's going on at the federal level, Kathy and I thought it was worth our time to talk about what's going on in each individual state. Not each individual state. Really, what we want to provide you is...
We have a lot of time if we're doing...
We have a lot of time, exactly. We'll start with Alabama. Exactly. No, we'll move on. Okay. Can you do the whole... I could never do the whole alphabetical order through the states, but I digress, as I often do. But what we want to talk about today are sort of the big ticket items, certainly what's making noise in different state houses, more looking at trends than trying to provide any deep dive into any particular legislation. And why should we care about this? I mean, clearly we understand that federal regulations directly impacts Medicare and Medicaid reimbursement rates. It also regulating commercial payers and the like. So why do we delve into these state law issues? Part of it is that legislative ideas spread like infections from one state house to another. And so appreciating what is on the radar in one state can help you see what's coming, either so you can run offense or defense on those legislative initiatives. And also just to encourage you to participate in this process. I mean, Kathy is famous for saying submit comments to CMS and other federal agencies, but at the same time, engage in this process at the state level. Either through your associations, as individuals, engaging with elected officials, but also with state regulators, because they have a direct impact on your day-to-day life. So what we're going to cover today is start out with some Medicaid topics. Then Kathy's going to pick up with legislation that regulates providers. I'll come back and kind of talk about what we're seeing in payer regulation, address telehealth, as well as provider licensure issues. So the first question is, how does one track developments in states beyond your own? And one resource that Kathy and I rely on heavily is the National Academy for State Health Policy. They maintain a number of trackers across all 50 states and the territories by different topics. The Academy also is very engaged in providing support for local legislators. So they draft sample legislation, they do studies on the impact of legislation and the like. So they are a fabulous resource in that regard. But of course, with these resources, one has to take it with a grain of salt, because the Academy's strategic partners are primarily payers. And so they definitely have I don't know that's safe to say. I think there's an appreciation that the funding for these activities is primarily coming from the payer side, and we'll leave it at that. I have not identified a similar a nonpartisan think tank that's necessarily on the provider side. Certainly the national associations like AMA and AHA have been involved in this, but not truly from these tracking it at the state health policy level. So with that, you want to add to all of my caveats, Kathy?
No, I'm ready to go.
Okay, let's talk about Medicaid coverage expansion. So here we are, after the ACA passed back in 2012, we're still talking about the provisions in the ACA that provide an accelerated match for those states that expand the eligible population up to individuals that earn 138% of the federal poverty level. There still are 10 states two of which are represented right now, Kansas and Florida, that have not expanded the Medicaid population as under the ACA authority. But at the same time, we are still watching closely states where they have expanded, but they are subject to renewal. So they expanded for only a certain period of time. There are states that are looking at repeal. Those initiatives have not gone away. And there are states that are sort of thinking, can we do this differently? And in part, that's the same conversation that's going on in these 10 states that have not expanded. So this is the questions of, do we include work requirements? Do we provide for increased primary care payments as an incentive to expand Medicaid? And do we look at what, for example, the state of Arkansas did, and they take their expansion population, and actually it's a private option. It's an insured product through a private insurance company as opposed to the state Medicaid program. So still lots of conversations going on in state houses around the broad expansion of the eligible population. The other area of coverage expansion that we've heard a lot about in 2023 is maternal health. When CMS has previously announced that those states that elect can elect to expand the eligibility for an individual to 12 months postpartum. So I think previous to CMS taking this action, was it 8 weeks, Kathy? I think was the coverage provision at the federal level. Again, states have to opt into this. It's been very well received. There are now at this point only 8 states remaining that have not expanded coverage to include 1 year postpartum. Sorry. The other interesting development here, it's a very recent announcement by the Center for Medicare and Medicaid Innovation. Their new Transforming Maternal Health model is a state-based partnership. There will be a limited number of states that will be awarded to participate in this particular initiative, but it is looking at creative ways to expand coverage to better support maternal health in the Medicaid program and beyond even. Another interesting development in coverage expansion is what we pay for with Medicaid. We tend to think Medicaid is payments made to providers for healthcare services, but in several states have taken up the Biden administration on its offer to start using Medicaid funds for social service programs, on the idea that these are programs that improve health or help overcome barriers to health, then that's an appropriate expenditure of funds under Medicaid. So this would include homelessness programs, food and nutrition programs seem to be the two that are leading the charge right now. Several states have amended their plans to incorporate payment for those services. The other interesting expansion of Medicaid expenditures is gun violence. Again, at the offer of the Biden administration, we have several states now that are using federal Medicaid dollars on gun violence initiatives. Now, when I say federal Medicaid dollars, what's happening here is the state saying, yes, we will cover these services using Medicaid dollars, which means then they get the federal match, their state percentage of federal match. So rather than having a state homelessness program funded exclusively by the states, you now have a state homelessness program funded in part by the federal government. So that's sort of where these interesting expansions are going. Along those lines, you see what California has done recently is expanding Medi-Cal coverage to undocumented immigrants. And that program just launched, certainly going through some growing pains at this point in time, but certainly something to watch as well. So continuing on the Medicaid theme, let's talk about Medicaid payments. And I'm focused here particularly on payments to providers. Our states are certainly grappling with the aftermath of the PHE. One significant benefit to states that federal legislation provided during the PHE was an increase in the match percentage. So states vary significantly in their matches from 50% up to almost 70 now. During the PHE, Congress said we're going to up everyone's match by 6.2%. So states had significantly more federal dollars coming in. So when you spend $1 of Medicaid, in your state, you were getting $1.62 back from, 6.2% more back from the federal government. A lot of that was used to enhance payments to providers during the PHE, to expand benefits during the PHE, and beyond just the FMAP percentage increase, there was other dollars that were coming into the states to support their Medicaid programs. So what do states now do with those dollars going away? One area of interest is, do we make changes to Medicaid provider assessments? If you have not delved into the wonderful world of provider assessments or provider taxes, this is a vehicle to generate state dollars that can be used for then the federal match. So rather than drawing dollars out of state revenues, states tax certain healthcare providers. So there's hospitals, skilled nursing facilities, and the like. They'll have a special tax that those providers pay, generally based on a percentage of patient revenues. And those dollars are collected by the state, and the state uses those to post dollars to receive the federal match in Medicare. And so because you get more for every dollar you spend, that then has the advantage of going back to the providers. So the providers spend $1 in taxes, but get significantly more back in payments for services furnished for Medicaid beneficiaries. Nearly every state, well, every state except Alaska, has some form of provider assessments. States have expanded to different types of providers that they have. Now, there are definitely federal rules you have to play in when you use these provider assessments. The 6% cap probably being the most significant. It's not technically a cap, but it's at the point that you go above 6%, you can no longer have any provision for hold harmless to a particular provider who is taxed. So there's no guarantee that provider is going to get the money back that they're taxed above that percentage. So typically states say right under that 6%, and about 37 states are sitting at 5.5 for some of their providers. So not a lot of room to increase those provider assessments, but you can look at who is subject to the provider tax. Can we expand it? If we don't currently have a provider tax for long-term care, can we expand to include that? Or are we going to restructure existing taxes so that we're getting more dollars into certain providers' hands? There's certainly a lot more federal scrutiny. I think it was early last year, CMS published some guidance out to the states on how they implement provider taxes. One particular concern that CMS called out was a scheme of a provider tax where everyone is paying in, knowing that the dollars are going to come back based primarily on Medicaid payments. So what happens with providers that do not have a high percentage of Medicaid patients? So they are less likely to see the same dollars coming back. So Safety Net Hospital pays the tax, it's going to see more revenue coming in for services provided for Medicaid beneficiaries. But what about the other hospitals, your suburban hospital that doesn't have that Medicaid population? What some states are doing, oftentimes through their state hospital association or other vehicle, is there are agreements between the hospitals that then reallocate the dollars as they come in the door. So to encourage the state, to encourage those hospitals that have low Medicaid to participate in these provider taxes, rather and appreciating the hold harmless restrictions in the federal law, rather than the state creating the vehicle for the provider tax and how it's then distributed, and providing protection for those, we'll just call them the suburban hospitals for the sake of this conversation. The hospitals themselves agree to the distribution, and CMS is like, we don't like this. We're not sure it works. So it's going to be interesting if CMS will insist that it has the authority to regulate those agreements, or whether it's going to continue to permit those. So it's definitely an area of a lot of interest by the states to generate those additional revenues, but interest by the feds to ensure that that's not being abused. And certainly we'd be remiss not to note the fact that there are budget hawks that have identified lowering that threshold from 6% down as a way to generate savings in the federal budget, and it's significant. There's analyses I've seen where you go from 6% to 3%, and how that's likely to reduce spending on Medicaid, at least federal spending on Medicaid. So it's an interesting area to keep on your radar screen. You're also seeing states talking about changing their fee-for-service reimbursement rates. Nearly all states have increased rates to keep up with inflation and to address workforce shortages. Some states have reduced payments, the fee-for-service payments, but they have been tied to increases in supplemental payments. So one of those states is Kansas. We've seen rates go down for hospitals, but it's been aligned with an increase in supplemental payments, either DISH payments or uncompensated care payments. So it's just paying differently for services, and you're seeing changes there. What you're not seeing at the state level are using provider rates, at least the state published provider rates, as a vehicle to control Medicaid spending. Now, of course, the question then is, that's the state published rate, but what about the MCOs? Because the Medicaid MCOs go out and negotiate their contracts with the payers. Generally, in some states, the state published fee schedule is the floor. You can't go lower than that. In other states, it's not considered a floor. So we obviously have, in addition to watching what's going on at that rate setting level at the state, how is the state regulating its contracted MCOs in terms of their provider payments, and how are negotiations between providers and payers occurring? Because all of that is going to go into the mix of what you're receiving in reimbursement for your Medicaid patients. Kathy, we would be remiss again not to talk about still pending DISH cuts.
Right.
If you want, I'll let you comment on that, since you follow that more closely than I.
Well, when we start looking at the issue of potential reductions in Medicaid spending, we do have, I guess this goes back to the Affordable Care Act and the expectation that we were going to have everybody covered under some sort of expanded Medicaid program, all of our low-income individuals. But as Marty said, we've got 10 states that still have not expanded. So included in the legislation was a provision that would reduce disproportionate share funding under the Medicaid program. It was expected to begin a few years after the ACA went into effect, and it was to reduce $8 billion per year over, I believe, a 5-year period. This has gotten kicked down the road repeatedly. Now we're at the point that rather than getting kicked down the road from year to year, we're getting kicked down the road from month to month, because we were expecting to see something in December that would delay this. We were then looking, because the can had been kicked to February 3rd, and now it's been kicked to the first week in March. We don't know what's going to happen, but if Congress doesn't step in and delay this, heaven forbid they actually eliminate this requirement, but if they don't delay it, we're looking at $8 billion taken out of state disproportionate share dollars. This isn't Medicare DISH, this is state DISH, but reduced immediately.
And it's interesting, Kathy, in doing
and
the research.
They're only looking at kicking it to 2026 if they do kick it.
Okay. But as I was doing the research on this, I was looking for any mention of state contingency plans with the loss of those DISH dollars, and I didn't see anything. So it's certainly, we don't like to talk about things we hope will never happen. And we hope they keep kicking the can until you and I are finally in retirement. But you've got to start thinking about how that's going to impact, especially safety net hospitals.
Well, and it's the issue of it's not just the state who needs to be looking at it, but the providers need to be talking to their state Medicaid agencies and others in terms of what does this mean to me, and what will we do? Putting a contingency in place.
Last topic under Medicaid is value-based payment arrangements. Every state has something on the drawing board that they want to pursue in this regard. This is primarily accomplished by terms of the state contracts with their MCOs and their expectations for the MCOs to stand up these different types of value-based arrangement, whether that's pay for performance, some sort of shared savings, episodic payment models. You're sort of seeing all of that in play in state negotiations with MCOs. Also, you have some all-payer initiatives going on, and most notable here is the Center for Medicare and Medicaid Innovations AHEAD model. This would be an all-payer approach, but focused with the state Medicaid agency leading the charge. There are 8 states that will be selected for this program. And again, it's intended to create sort of a broad alternative payment model within state Medicaid programs. So certainly keep your eye on what's happening with, if your state's applying for AHEAD, and even beyond AHEAD, what are other initiatives we're going to see on a much broader scale beyond this? Let's see what we can negotiate with the MCOs. Okay, Kathy, I'm kicking it to you.
All right. I'm going to talk a little bit about quality standards and staffing levels. Interesting as we start to look at this, Martie has already mentioned the majority of states have already expanded their maternal health coverage for a period of a year postpartum. We do still have a few states that are holding out. But to kind of link maternal health and behavioral health, we do have states, Arkansas as an example, that is essentially mandating a screening for depression for all new moms, which I think is a very interesting thing, kind of very sensitive to me from a family situation. We have a lot of focus on behavioral health, really from a Medicaid perspective in terms of expanding Medicaid coverage for behavioral health services, focus on behavioral health parity. But when we start looking, I'm going to go back to maternal health because I wanted to say that a number of states are really looking at mortality and morbidity and doing studies, mandating studies within the state, programs that actually will begin to review all maternal deaths and to look at those in terms of what went wrong, how could this have been addressed, et cetera. We also do have that issue of states responding to the Dobbs decision at the Supreme Court in terms of adopting regulations or as it ties to abortion. On the primary care issue, we do have a lot of states that are investing dollars into primary care initiatives to expand the number of primary care practitioners in the state. They're looking at innovative ways to pay for primary care. And I think a couple of states that we've identified in order to actually, I guess I would say, entice physicians to not align or to become employed by a healthcare provider, let's say a hospital, they are actually offering state tax credits for those primary care physicians who have an ownership interest in private practice. So it's keeping the doc in private practice. A couple of states that I identified right off, they're offering $20,000 state tax credits if you stay in private practice as opposed to being purchased and becoming a part of a large hospital system. States are looking also to expand primary care by funding residency slots, just a number of different programs that they're putting in place to expand.
Kathy, I'm going to go back to this idea of the tax credits. I mean,
I love it.
Aren't we sort of just, upping the arms race? Because if there's a new incentive for a practitioner to remain in private practice, that's just putting the pressure on the hospital that wants to employ the doc to up the salary to make up that difference.
That could be, absolutely, but there are those docs who really, I would say, like their independence, and this will be one more thing that entices them. So, and let's just go into funding and dollars. Can we really afford to keep upping the payments to the docs as we purchase their practices? We just talked about Medicaid funding. What if it goes down? How do we do this? So are the dollars there to continue to acquire? And you're going to talk in a little bit about physician payment rates. So the hospital that gets paid those physician rates, can they really afford this? So looking at workforce issues, nurse to patient staffing ratios, we know that we have federal requirements now for long-term care facilities as it relates to predominantly RNs. Interesting that regulation did not address LPNs, which provide the majority of services, I believe, in many of these long-term care facilities. But California is actually the only state that has a mandated staffing levels based upon specialty, nurse specialty. This is within hospitals and applying to all units and services within the hospitals. How many nurses do I have to have per patient in the OR? How many do I have to have in pediatrics, et cetera? And I thought it was very interesting that they are the only ones who have actually mandated at that level, getting it down to the overall level. But we are seeing, as we look at legislation, many states that are looking at staffing committees, and they are mandating how many nurses have to be on the staffing committees, not how many nurses are to patients in terms of a staffing level. They're leaving it to the individual hospital to establish the nurse-patient ratio, but they are establishing nurse to CEO, CFO, et cetera, ratios for the committees that actually develop their staffing plan. Thought that was fascinating, that they aren't looking at the individual nurse staffing ratios as much as they are looking at the committee ratios. And we've even within this program of the ratios, most of them are based strictly on clinical staff, but we're seeing as an example in Oregon where they are addressing staffing plans for allied health workers too, even to the point of whether it be in your lab, whether it be in dietary, et cetera. What is your staffing plan? How do you provide coverage for breaks? What are you going to do for this? And they are actually starting to look at this and require that your staffing committees look at a lot more than just the nursing level. From a minimum wage perspective, we do have states that are looking at minimum wages. Currently, we range from $8.75 an hour, I believe, in West Virginia to over $16 in Washington State. But as we see these minimum wage increases, this does get into who can we hire, how many can we hire, et cetera. We also see that issue of competition across hospitals within the community in terms of hiring bonuses and the like. Haven't seen anything that ends that. Let's take a look at price transparency.
Wait, I thought you said this was where we're dealing with state laws. This sounds like a federal.
We are, because it's interesting. Well, first of all, we are dealing with state laws. We don't have a federal law. All right, we do not have a federal law as it relates to price transparency. We have an executive order with implementing regulations. So stay tuned, that could change real soon. But when we start looking at what the various states are doing, we are seeing that they are definitely on the price transparency bandwagon. Some of them have been there for a number of years. Just some of the things that they're looking at, number of states are looking to prohibit facility fees for services provided at an off-campus location or for telehealth unless it was provided in an emergency situation. We have other states, as an example, Massachusetts, that's putting a cap on facility fees. I think they were looking at a $30 facility fee cap. Meanwhile, if you're going to be providing services at a hospital-based outpatient department, you are going to have to, in many states, provide notice to the patient that the services could be received at a lower rate if you did not go to a hospital-based clinic. So it's the notification of the patient. It is the issue of not being able to charge facility fees, et cetera, that we are starting to see. While we have requirements under the No Surprises Act for good faith estimates, we have states that are looking to require advance notice of all service, all charges, and for all services other than emergency situations. Here is what you are going to be charged for what we think we are doing for you today. That's going to be very difficult. We've had trouble with that, even getting it figured out from a federal level. But now we are looking at states also mandating this. Disclosure to patients if their cost sharing for a covered service exceeds the cash pay price, the self-pay price. You have, as an example, insurance with a high deductible. And I'm going to need to collect $3,000 from you today for this service. However, if you want to just pay cash, charge is going to be $250. And they're going to have to disclose that. I think as we have states mandating that be disclosed, this is going to be in the media right and left, because the patient is going to take the little form that says, you owe $3,000 unless you want to pay cash for the whole thing, and then it's going to be. And it's going to be in the news, and we're going to have a lot of people who perhaps have high deductible insurance products who say, I don't know if I want to play anymore.
Okay, Kathy, I want to go back up to facility fees because today I'm controlling the slides, so I get to decide. And you took a look at this legislation. Are these written so that it's prohibiting a hospital from negotiating with a commercial payer a different rate for services furnished in a facility versus an off-campus hospital department? Versus...
It is literally, no, it is literally a line item on the bill that is facility fee. Okay, you cannot charge this. I mean, let's look at telehealth. You can charge for the telehealth service. You can't charge for the location of providing that service. All right.
But I mean, it's agnostic as to whether it's self-pay or commercial pay.
Exactly.
State health plan. It's all right. Applying across the board. Very interesting. Very interesting. And again, hard to watch this stuff when it's going on, because if it happens in one state and they're successful, it keeps bleeding over to the next state.
And it's also the question of how does a state define facility fee? Is it that line item on the bill that says facility fee? Does somebody get carried away and say clinic charge? Because that is probably your E&M level.
Interesting.
All right. So again, you do need to pay attention to make sure they don't interpret something inappropriately.
Yeah. Devil in the details, right?
Yeah. Go back.
Yeah, come on, you're asking a lot out of me, girl. Okay, there we go.
There are, I can't tell you how many states are looking to implement regulations that say, or laws that say, you must be in compliance with federal price transparency. And several of them say federal price transparency laws. There aren't any, but majority of them do say regulations. And what they're doing is, although non-compliance gets you a penalty at the federal level, I think only 14 hospitals have been penalized so far, but there is also going to be a penalty associated with it from the state level. Some of them are from a dollar amount. Others are actually coming in and saying, if failure to comply, you're not going to be able to collect from the patient.
Now, okay, so in these laws, are these instances where there's been a determination at the federal level by a federal agency of noncompliance, or are the states empowering themselves to decide?
The state determining noncompliance.
And we know we've seen a lot of issues around that. Of
Absolutely.
what is compliance, right? Very different definitions of that, because you have CMS versus watchdogs, reviewing hospital postings and coming up with very different answers.
Well, as a matter of fact, Marty, the next bullet kind of gets exactly into that, because we've got states that are enacting laws that parallel exactly what you have to do on the federal level in terms of posting a machine readable file and 300 shoppable services. What's missing in that?
What happens when the federal law changes?
Well, no, what happens is 300 shoppable services regulation, not executive order, but regulation allowed for a price estimator.
Right.
So the way the states are writing it, it is shoppable services. You must have shoppable services. Well, you go in and you argue, but, well, that doesn't help everybody. It doesn't help the patient who doesn't have insurance, because a price estimator is going in and querying their insurance for what the patient is going to owe. That doesn't help the self-pay patient who wants to know what they're going to owe for that chest x-ray.
Yeah.
So the states are implementing directly from the executive order, as opposed to looking at the requirements of the regulation at the state level, at the federal level.
Yeah, and I mean the majority of hospitals use price estimators as opposed to the shoppable services list. So
well, and we may as well say it now. We also have federal legislation that would allow you to use price estimators, but it would require shoppable services in addition. So also on price transparency, I mentioned that non-compliance hospitals being prohibited from billing patients. If it is found that you are non-compliant, you would also have to refund any payments that were received as of the date of the transparency violation. Think about that. Think about if you suddenly are found not to have been compliant as of last February, refunding payments received. Others are expanding transparency to medical practices, to dental practices, and to ambulatory surgical centers. Along the line of price transparency, I know Florida is looking at legislation that would limit your time period to collect medical debt. We have states that are looking at creation of all payer claims databases. We also have states that are looking at eliminating the all payer claims database that they already have. This is a great opportunity to have that and to be able to actually look at the claims that have been submitted and to have them for analysis, but it also gets expensive.
Yeah, but we know this. We know when we look at states like Wisconsin that have fabulous all payer claims databases, your ability to look at those and track trends and just enormously beneficial on the provider side. But then many states don't have that. And to say that we're going to repeal them, I assume they're just dissatisfied with the level of data they've been receiving, and that's the justification for the repeal.
And we'll talk more about drug pricing in a minute, but just know that many are requiring tracking of price increases for drugs. We have reporting requirements if your wholesale acquisition cost is above a certain threshold, and you've got to notify in advance. But the one that's very interesting to me is we've got several states, Indiana an example, that is now going to be requiring reporting of rate comparisons as a percentage of Medicare, to a percentage of Medicare. So you currently are receiving this amount of money and charge this amount of money. How does that compare to what Medicare would pay? Surprise billing, just in the, because of time, again, violation of those federal laws related to surprise billing would be considered deceptive trade practices. There would be caps on your charges exceeding your estimate other than in an emergency situation. Requirements for ambulance providers requiring insurance plans to reimburse for transports for a non-participating ambulance provider. That would be a very interesting one. Prohibitions on physician balance billing within their office practice and elsewhere. Requirements for patients' Bill of Rights. Most states have them, but not all do. I love this one. Requiring providers to specify in a patient bill the dollar amount that you're willing to accept as payment in full. So here is your bill. You owe $989. However, we will consider this paid in full if you pay. I mean, I thought that was what this is how much you owe is, but they are actually requiring on a patient bill for you to identify how much you would be willing to accept as payment in full. I don't know who makes that decision. So some of the pre-existing state laws as it relates to surprise billing, remember under the federal surprise billing, some things revert to the state level for the IDR process and you follow state law. Some states are actually looking at repealing their existing state law. Therefore, everything goes to the federal level.
These.
I love it.
I love that because I mean we've been dealing with these decisions. Is this federal or state
Where do I
IDR
take
process?
this particular claim? Does it go state or federal? Well, let's just make it easy for you, by saying everything's federal.
Yeah, I've always been proud of the state of Kansas that we, under HIPAA, if the law is more stringent, the state law is more stringent, the state law governs, which creates all sorts of nightmares trying to figure out what rules apply. In Kansas, they just said across the board, nothing is more stringent than HIPAA. So as long as you're complying with HIPAA, those privacy rules work, and it certainly simplified the world for providers. I can hope to say what happened here with the IDR process because it is just mind-bogglingly confusing. To figure out where you should be. And that's where a lot of the delays in the process are. Okay, sorry.
All right.
But I pontificate. Go ahead.
In terms of tax-exempt hospitals, community benefits, I'm just concerned about time, so I'm going to touch on a couple of these. A lot of requirements related to limitations on how much a hospital can increase their overall expenditures. I think that one's going to be very interesting to start tracking because there are new drugs, new technologies, et cetera, that better improve patient health and care. How do you say you can't buy it because you're at your limit? Concerned about that. Requirements for tax-exempt hospitals to present their community benefit implementation plan to the public. That already exists in a number of states, reporting it on your website. One that I think is very interesting is Illinois requiring hospitals to report how their community benefit spending relates to their community health needs assessment. So you are linking the two. I am clearly going to link what my community needs to what I'm spending money on. Okay, so I like it. A lot of states are now beginning to look at tax-exempt status or within their providers. In Florida, we have what we call independent hospital districts, and there is legislation that was passed, I believe, a year ago that required a review of the tax districts, but now pending legislation in Florida this year would call for the evaluation of the benefit to the residents of the community of supporting the hospital tax district. And then in Texas, we actually have a requirement for this year, a report that would look at the value of the charity care provided by the hospital and the benefit of the tax exemption. And the idea is to improve transparency of what are you getting for your tax dollars. For prescription drug affordability, lots of things I mentioned already that they were looking at how to better identify and track price increases across drugs and like that. We've got drug boards that are being created for this. We've got limitations for pharmacy benefit managers from increasing the burden, the cost burden on the individual patients, a prohibition on unsupported price increases. The one issue, and I know we've got a couple of slides on this, that I just wanted to, again, because of time, say what we're dealing with here is one issue that is a positive. When we start looking to control the price of drugs, whether on the next slide, we're talking about importing drugs from Canada. We've already done that in Florida, but when we start looking at this, this is an issue that should be positive for the patient. It should be positive for the provider who is purchasing these drugs to make available to their patients. It should actually be positive for payers as well, who are paying for these drugs through your insurance. So a united front is probably the right way to go when we start looking at prescription drug affordability. And with that, I get to turn it back to Martie, I think.
Yes, you're correct. Let's talk about payer regulation. So what are states looking at to address practices by payers that are at odds with providers' interests? Certainly great deal of interest around prior authorizations. The American Medical Association released model legislation. Several states have picked that up, and bills have been introduced that really cover the gamut on addressing the PA issue, from establishing required response times, requiring that any adverse determination, any denial, any refusal of prior authorization be completed by a physician who's licensed in the same state and in the same specialty as the physician requesting the prior authorization. Prohibiting retroactive denials of care as pre-authorized. I know we've seen this issue skyrocket, that even after you've gone through the PA process on the back end, you end up with a denial. Prohibiting that practice by payers, the length of time that the authorization remains valid, and then I like this one. This is my favorite: requiring public release of insurers' prior authorization data by drug and service, so that we can basically post in the market square the behavior of different payers and how they treat providers, so that we have that information as transparent as possible. So we'll see where prior authorization goes and how, of course, that's going to intersect with the new PA regulation that was released, final rule that was released by CMS 2 weeks ago. On the area of coverage mandates, states continue to go in on pretty ad hoc basis, mandating coverage for certain types of services, certain types of drugs, generally often in response to a media outrage over an insurance company denying coverage for a particular treatment. The issue here we've got to address is that you can create these coverage mandates. How are you going to enforce them? Because state departments of insurance, their primary job is make sure insurers remain solvent. And that's where they spend their enforcement authority. But typically these coverage mandates, it falls to these states' departments of insurance to enforce, to receive complaints, and to enforce against any health insurer in the state that refuses to provide coverage. So there's that dangerous area is you can write the law, but will the law actually impact the behavior change you want to see, given the need for enforcement? And finally, you're seeing a lot of activity on consumer cost sharing. That mandating that any amount paid by a consumer must be applied to their annual cost sharing. We see more policies that say, yes, this applies to your deductible. No, this does not apply to your deductible. And this is state law saying everything that the consumer pays is going to count towards those deductibles. Again, what are the world of unintended consequences with that change we need to consider? And then limiting out-of-pocket costs for prescription drugs and other high-value services is another area where there's a number of pending legislations in the states today. So that's sort of what we see going on the payer side. Let's talk about telehealth, because it's an issue that has both federal and state implications here. A number of states are expanding Medicaid coverage for different types of telehealth services, both the types of services, the types of conditions, providing coverage for those. You're seeing states implementing legislation that prohibit providers or payers from requiring that a patient receive services via telehealth. so that you cannot limit the benefit to only a telehealth benefit. So some concern there in terms of access to care being overly virtual as opposed to maintaining that direct patient relationship. And then there are a number of states that are changing their rules with regard to qualification for Medicaid participation and eliminating the requirement that the provider has to be present in the state as a condition of Medicaid participation. This allowing sort of those multi-state telehealth companies that don't physically have people in the state being able to provide services to Medicaid beneficiaries in those states.
Marty, they're requiring physical presence?
They're eliminating the requirement.
Eliminating the requirement for physical presence. Okay.
Yeah. So it's causing, I mean, obviously some controversy with the providers present in the state.
Exactly.
They're seeing the competition coming in as a result of that. On the commercial payer fronts, I think nearly every state now has coverage parity. That if a service is provided in person, if an equivalent service can be provided via telehealth, that it must be covered. But we're seeing more movement on the payment parity. And again, not universal payment parity, but instead focusing on, again, specific conditions and services that you have to provide the same payment regardless of whether provided in person or via telehealth. Lots of movement in the licensure world. As this impacts telehealth, because you have to be licensed in the state where the patient resides. Typically, that's the rule. And so how do we handle licensure for telehealth providers? That's going to be the interstate compacts. We've seen a significant number of states now approve participation in the physician compact as well as the nurse compact. I think you're in the 40s of states that are participating in both of those right now. And again, other state legislation being introduced to expand that even broader. Professional practice standards in the telehealth space, that's a code word for do you have to see the patient in person first before you initiate telehealth services. More states going towards that requirement, interestingly, as well as clarifying in state law that you can use telehealth to establish a patient-physician relationship and the protections that are afforded to those relationships. Online prescribing, the states are busy beavers. Looking for different types of restrictions on online prescribing, safeguards. Certainly in play here is what we're going to see out of DEA, hopefully by the end of this year, on how they're going to address the prescribing of controlled substances. And finally, a number of demonstration programs trying to prove the value of telehealth, particularly in behavioral health and mental health arenas. Finally, reference source. If you are not familiar with the Center for Connected Health Policy, I'd like to introduce you. Again, a resource we rely on heavily. They do a great job tracking both legislation pending in states, but also state policy as it exists, from everything from licensure to remote monitoring, the whole gamut. But they're a great resource as a funded telehealth center. Finally, we reach number 10 on the, licensure. Licensure is number 9. I got ahead of myself. Whoops! I wanted to get to the.
Actually, Marty, I just want you to know that licensure is 9 and 10.
Oh, good. Well, I can't count to 10, and no one's surprised by that. That knows how I deal with numbers around here. The definition of a hospital.
Yes, an attorney.
I'm sorry.
I said she is an attorney.
Exactly. Well, recovering as best I can. Definition of a hospital. How state regs typically think of, the little building is the hospital with the H on it. But that certainly is at odds with hospital at home programs. So states reconsidering how they're going to change their licensure rules to allow for hospital at home services. Similarly, the rural emergency hospital program, which has no inpatient beds, states are figuring out how they're creating licensure to allow conversion in their states by hospitals to the rural emergency hospital program. A lot of action in the certificate of need space. A lot of states are looking at repealing their existing certificate of need programs. A lot of states looking at adding new certificate of need programs. So a lot of action all over the place, and certainly something you want to be aware of. States are also trying to tighten up the processes. If they have existing con processes, they're tightening the time frame, because certainly we are very familiar with the fact that waiting for a con slows down these processes on transactions, slows down building projects and capital investments. And so can we keep the con that sounds terrible. Keep the con going in terms of reviewing those activities, but at the same time, not creating an unnecessary hindrance when those expanded services are needed in the community. It is number 10, licensure. The other half of licensure. This is just Kathy's fun. Go on.
Yeah, I just thought I would share. I thought this one was very interesting. I don't know if this should go under primary care or licensure or what, but Florida is actually looking at legislation. Again, you got to be EMTALA compliant, but a patient presents to the emergency room with a non-emergent condition, with a medical screening, and then you're going to be able to refer the patient. You would, an individual provider would need to establish a non-emergency care access plan, an NCAP, and you help the patient, refer them to a medical home. It is actually now going to also allow construction of a hospital-owned urgent care center co-located with or adjacent to the ED. So I am going to do my initial medical screening, determine that it is a non-emergent condition, and I'm going to divert the patient to urgent care.
I love that they're doing this as a licensure issue, right? I mean, it's like, it's a Medicare, similar to the Medicare conditions of participation. You know, the base rules for a state to give you a license as a hospital, you have to be, you know, helping these patients that are using your ER as a primary care facility.
Right, and this is you're going to help them establish a medical home. You're going to educate the patient of go to urgent care next time.
Sometimes these states are little laboratories of democracy, aren't they? It's a great initiative. I hope we can see it expand further. Okay, this is what should have been labeled number 10. I apologize. If it's not one thing, it's another. These are just other things that are popping up at the states you may want to be aware. The multi-billion-dollar opioid settlement spending, you know, states are now getting those dollars funded. Unlike tobacco, where, you know, we paid for a lot of roads with tobacco dollars, these settlements all require the dollars be utilized on substance use disorder prevention, training, and treatment. And so now we're starting to see the state stepping in and how they're going to regulate that spending. And lots of questions around use of those dollars for policing, whether that's going to be appropriate. So expect some more movement here. Where there's money, there is controversy, as they say. Limitations on increases in state's healthcare spending. Kathy, what's that one?
Essentially on, you know, capping the amount a state can increase its overall healthcare spending from one year to the next. Very simple, but just capping. We're not, if we spent this much this year, we can only go up this much the following year.
So it's state Medicaid plans, state health plans, that type of, the state spending on healthcare.
Yeah,
Got it. Okay.
The state spent what the state itself spends.
Okay. You talked about the state tax credits already for the physicians that remain in private practice. Certainly looking at new ways to fund primary care residency slots. It's always been an issue. The annual report for hospitals on all cap expenditures. So I guess that's a pre-con, right? We'll call it the pre-con, exactly. And finally, you know, it's always out there. States looking at single payer systems. They look at what Vermont and Maryland have done. It's sort of their creative thinking outside of the box, and other states looking at initiatives around that. Again, trying to be the laboratories to figure these things out. Of course, we got 1 minute left. So
Marty, on that, I think it's interesting to see that some states have looked at a single payer perspective, but within, I guess it's New Jersey, they are actually looking at Medicare for all and calling it Medicare for all as opposed to a single payer system.
Interesting. Lots of stuff going on in Washington. I think Kathy and I are going to address these during our second HCRR for the month of February, because certainly by then we'll have some idea where the budget negotiations are going. But next up for Healthcare Regulatory Roundup on February 7th, I'm going to be joined with my colleagues Valerie Rock, Lori Foley, and Angie Caldwell, and we're going to talk about G2211. The good news is CMS published a MedLearn Matters article last week addressing appropriate billing for 2211. It's critical for physician practices to be capturing this new additional revenue, and so we're going to talk about how to do it right, how not to get in trouble. So we hope you'll be able to join us then.
Meanwhile, go and find out what's going on in your state and get engaged.
Yeah. And finally, last but not least, we love to hear from you on topics you'd like us to talk about. So as Caitlin said at the top, when we finally stop talking, you're directed to a survey. In that survey, if you've got a topic you'd like us to address, please include that. We really do lean on that heavily to keep this Regulatory Roundup series going.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.